Hey everyone, this is Chaplain Lance Lormand. Decided today to record this video for LinkedIn. And to my understanding, it's not actually streaming to LinkedIn. So this is not the first time I've done live streaming, but the first time since COVID when we were all doing it, that in Zoom. So my promise to you is to get that connection between social media and Riverside fixed so that in the future, if there are more videos like this that come out, they're automatically live streamed to LinkedIn, but also to my YouTube page and others. Really, the reason for recording this video at all is the incessant requests I've gotten from people trying to understand what it is I'm talking about when I'm making posts online, when I'm referencing different studies which have recently been published, ones which are on the horizon, and questions even further out. So, after a long time of sort of receiving those requests by chaplains and mental health providers and others who were interested in the topic of moral injury, I decided, you know what, I ought to just say it and tell people sort of what I've seen, the researchers I work alongside and with, and where I think this conversation is going in the future. So before I even start any of that, I have to give the standard disclosure, which is that everything I'm saying in this video, these are my opinions. I am a military chaplain, but the views that I'm sharing are my views. They're not necessarily the views of the Department of War or the United States Air Force or the Space Force or any other military agency. I do think that I am pretty closely connected to those in the military and maybe could speak to the views of chaplains in general, but like in any workplace, there are going to be people who disagree. So the first thing is, what is a topic I'm looking to address? Really, what I'm wanting to spend some time talking about is what I've called the medicalization of moral injury, or if you will, sort of the pathologizing of human suffering. Now, I've referenced a couple articles and tools in the comments on my LinkedIn page. There's so much more that I could have put there. One book that I mentioned is Heal Thyself by Dr. Keith Metter. So he is actually just recently retired as the director of the Doctorate of Ministry program at Vanderbilt Divinity School, which is where I did my DMin. That doctorate is in integrative chaplaincy, and it's also a certificate in mental health integration and chaplain services, which is a specialization within the Department of Veterans Affairs. So there's the mixed program, the mental health integration and chaplain services program, which has also sort of been expanded to a doctorate of ministry there at VDS. Dr. Metter is one of the many professors there, and many of the people that I will quote are also, faculty there, and I consider to be friends. His book, Heal Thyself, was written, I believe, after the death of his wife. And if you've ever met with him or seen any of his videos online, that was a profound moment in his life. What's interesting about Dr. Metter and others like those at Duke that I may mention, like Warren Kinghorn, is that they're both people of faith. Many of them are actually ordained in some kind of church tradition or religious tradition, but they're clinicians as well. So a Warren Kinghorn, for example, is a psychologist. He works in the Department of Veterans Affairs in Raleigh, Durham. And his book, Wayfaring, is probably another one that I would recommend that gets at these questions of medicalization, you know, pathologizing suffering, and also the positive things about the medical mental health system. So before I even get to any of that, though, I think the first question is, what do we mean by moral injury? So that's a good question. There have been lots of competing answers to that question over the last 10 years. I think probably the foundational text would be Achilles in Vietnam, which was written after the war. Um, we know, of course, like PTSD as a diagnosis sort of emerged from that experience in Vietnam. And yet we recognize it throughout human history. We can look back at the Bible, the Psalms and other writings and see things that look a lot like post traumatic stress disorder. Um, Moral injury emerged from the same period. I think part of what's important to distinguish is why is moral injury distinct from PTSD, and then how has that led to the current trajectory towards medicalization. Obviously, PTSD today is a recognized diagnosis in the DSM-5, the Diagnostic and Statistical Manual for Mental Health Conditions. which is the Bible gold standard of the APA and providers across the country. Um, PTSD, I think, is pretty well understood. PTSD is about a loss of safety. It's about the sympathetic nervous system responding to triggers based on a significant event, trauma in the past in a person's life, wherein that person, when they're triggered, not only is remembering what happened, they're physiologically reliving what happened in their body. Another great book, of course, is The Body Keeps a Score, which I recommend to people often. Um, Moral injury, I think the researchers would say, emerged as a concept when the research community realized that PTSD did not really adequately describe everything that they were seeing in their patient populations. Um, so they would take that as an argument for the research community that through the process of pathologizing and creating ICD codes and creating a full diagnosis in the DSM, they realized that the language of the DSM did not always fit the presentation that they saw in their patients, or that there were adjacent things that PTSD did not cover. So they would say the process worked, if you will. Um, I'll give you sort of the typical example that I give people about the differences between the two. So imagine, you're a security forces member and you're in Afghanistan, and suddenly someone shoots behind a corner at you. Your fight or flight response is activated. You take your firearm, you return fire, and then you realize that the target struck. You go around the corner and you realize the target was a 16-year-old kid. Uh, that's a terrible, tragic thing that happened. So, 5, 10 years go by, and every 4th of July, when the fireworks go off, you're reminded, and you're more than reminded, you're reliving that experience in Afghanistan. Now, that's a sympathetic nervous system response wherein the fight or flight response is reactivated. Now, there's an aspect of moral injury in that case because obviously we know, we're trained, the law of armed conflict, we have no desire uh, to kill a combatant, even if, that combatant is a minor or a child. We've all probably seen movies like American Sniper where these kinds of hypothetical ethical dilemmas are brought up, and there are many real world examples of them. Well, for all of human history, when people have engaged in war, they've done it with swords, and before that, with clubs. And so you were in the space with the enemy. It was kill or be killed. And one person emerged victorious and one didn't. And I think that situation um, helps justify morally and ethically one's actions. So even though that person who shot at you was a teenager, it was either them or you, or it was either them or your teammates or your friends or your brothers or your sisters in arms. And that helps justify your actions. Now you may still have arousal, responses, and you may still have, PTSD symptoms in the future, but from a moral and ethical lens, for many people, it's easier to justify, tragic and terrible as it is. Now I want you to imagine a situation where you're not in this space. You were not there. Of course, everything we've learned with Russia and Ukraine, and prior to that with drone warfare, is that the future of war may not be in the body, if you will. Um, Imagine you're a predator pilot or a sensor operator, and for 4 weeks you are observing a target who is doing bad things. He's making bombs. He's killing Marines. He's hurting American service members, and obviously that's something you want to stop. I mean, you want your friends to go home, but then you also notice in your weeks long observation of him that every day at 5 o'clock he comes home and his kids run out and give him a big hug and they play soccer for an hour. And then finally mom says, "Hey, y'all come in to eat." And maybe not in those words. And you start to question, you see parts of the enemy that for all of human history, we have not seen. We know that our enemies are human beings, despite, the common desire for people to dehumanize the enemy for the sake of war. But we know that they have family members. We know that they have wives and husbands and children and mothers and fathers and people who care for them. And we've seen pictures since the dawn of photography confirming these things. But we haven't been able to take a peek around the curtain on the battlefield, if you will. And so finally, one day, your commander, let's say, says, all right, today is the day we're taking out this target. Remember, he's a bad guy, and he is. I mean, he's doing evil. He is a combatant, even though he's not in uniform, let's say. And so pull the trigger, bombs away, 5, 4, 3. Oh, by the way, um, you were told, the intel said, the kids are going to be gone. They're at school today, based on the pattern of life data. But then at that 2 second mark, the kids come running out to hug daddy. 1-0, boom, and they're gone. And you see it on live TV from the other side of the world. Now, that's maybe a failure of intelligence. Maybe school was canceled that day. Maybe it was a holiday we didn't know about. And there's any number of reasons why a situation like that could occur. And of course, just like the first situation, it's absolutely tragic and heartbreaking. But it's different from a PTSD type situation, even though someone may have PTSD as well. These things can be occurring simultaneously as a diagnosis or as a presentation, if you will. You weren't there. Unlike the soldier or the airman or the security forces member in the first scenario, it really was not kill or be killed. You were sitting in the safety of a, Windows computer somewhere on the other side of the world, and here in about an hour and a half, you're going to go have lunch, and then you'll come back from shift, and then you'll go home to family and kids, and they'll say, honey, what'd you do today? Now, that's much different than any kind of experience of war for all of human history. And it creates unique challenges. So, what I've observed, and I need to say up front that I'm speaking in general, like there are all kinds of qualifications that need to be made. But I worked, for example, in the inpatient mental health center at Brooke Army Medical Center. And I would give inexperienced providers this scenario, the one I just offered with the drone operator. And I would ask them, now, based on your training, freshly minted out of med school, PsyD, PhD, MD type providers, how would you respond to someone who comes to you with this story saying, I feel so guilty, it's all my fault, right? The standard in mental health, and again, this is not every situation. There are so many providers who are amazing, much more experienced, but the mindset is driven by cognitive behavioral therapy, which maybe at a future date I could unpack more. But there's a whole history beginning with Freud to the present day, wherein psychoanalysis of Freud and Jung and others became overturned by cognitive behavioral therapy, which is sort of the gold standard approach, sort of the first base standard of many like mental health modalities that are used by providers. What is interesting about CBT, I'll just say this, is that unlike psychoanalysis, in my opinion, CBT is not always asking why. It's not asking the why question. The goal of CBT is to challenge unproductive self-talk. So it's to the providers identifying in the care recipient self-talk, the story they're telling themselves that's not helpful, not productive, to challenge that in the hopes of creating a new story, better self-talk, more functional. And it's very much this whole realm of the medicalization of mental health and human suffering views man as a machine, and man is not a machine. So this is a fundamental difference, I think, between the approach of chaplains and the approach of a clinician, and that's where we're headed in this conversation. So imagine you're this young, inexperienced provider in the military, let's say, and someone comes to you with this story. They say it's all my fault, and so what do you do? Well, what most providers have have said is they question the unproductive self-talk. So how does that look? Well, if questioning the unproductive self-talk means, in essence, the short version up front is invalidating that person's feelings of grief and shame and guilt. So the provider says, well, how much of it is the Taliban's fault for creating bombs that kills Marines? I don't know, 20%. Well, how much of it is this man's fault for knowing that he would be a target of the U.S. military because of his actions against, uh, uniformed service members as a combatant, not in uniform? I don't know, 30%. Well, how much of it is, your commander's fault or the intel community's fault? I mean, you could go on, right? Now, do you know rationally, as the grieved person, that it's not all your fault? Yeah, I think yes. Like we know deep down that all of these things are at play, that it's not that simple. Now, let me ask you another question. Do you feel better having had your unproductive self-talk questioned? Probably not. I don't think I've had a single person say that, oh, now that my unproductive self-talk has, been questioned, I am free of the guilt and shame of what I experienced. And so we've had a system where, in a lot of cases, uh, patients, mental health patients, people, in the military medical system and outside of it, in the VA certainly, have for years had their story and their feelings of guilt and shame invalidated because guilt and shame is bad. Guilt and shame is unproductive. Guilt and shame is wrong. Guilt and shame is a problem. Um, Moral injury has a lot of definitions. I'm just going to share one with you. This is from the Shea Institute. It's that it's a betrayal of what is right, deeply held moral beliefs by a person, which could be yourself, or a legitimate authority, which could be someone else, in a high stakes situation. Now, this is one of many definitions. If my camera cuts out, it says it's reconnecting, and I'll just keep going. But the core of moral injury is that it's something I did wrong, I failed to prevent wrong, I saw someone else do wrong, I didn't stop someone else doing right. So it can be something that happened to you, something you did, or something that you witnessed that deeply violated your moral and ethical beliefs. So for instance, I've had patients who were, in the hospital who have shared stories like this. And I was the first person in 20 years who told them, yeah, it was wrong. Shouldn't have happened. I know all the background, but yeah, I agree with you. You shouldn't have done that. That shouldn't have happened. It was evil. The world has fallen, those kinds of things. And they were astonished and they were deeply grateful that a chaplain finally, after 15 plus years of talking to people, did not invalidate their feelings of guilt and shame. So this brings me kind of to the core of what I want to talk about, which is that the danger of framing human suffering as a disease. And this gets back to the book Heal Thyself, which I recommended earlier. The mental health community, this goes back to Freud and to the formation of psychology. And there's always a desire to sort of compare it to the hard sciences of the other providers. So, like a blood test is very clear, right? You either have it, the thing we're looking for, or you don't. And there's a tendency to view human suffering through the lens of disease. So I'll give you an example. Say we thought you had cancer. Okay. You've got a lump that shows up one day. It's painful. What do? You go to the hospital. The provider triages you. So they rule out things from most serious to less serious. They do a biopsy and they treat. So they follow standard of care, standard practice. They say you have a sarcoma or a carcinoma or what have you. And then the standard of care in that case is going to be, radiation therapy. It's going to be chemotherapy. It's going to be experimental drugs. Um, and then how do you know when you're cured? This is the key question. How do you know when you're cured of cancer? When it's totally obliterated, when you're symptom free, when suffering has ceased and it's absolutely gone and you're clear and maybe you go in for checkups. But the standard of health in that case is the absence of suffering, the absence of symptoms. Well, if you apply this disease model to mental health or to suffering, then what is the definition of health? The complete obliteration of suffering, the complete lack of anguish, pain, regret, guilt, all these negative feelings and experiences. This is fundamentally different from the religious perspective. This is fundamentally different from the approach of chaplains. I would propose to you that never in my life has that been the case. Can you think of a period in your life where you were completely free of suffering, where there was, no anguish, no loss of a grandparent, no pending, medical issue? I mean, that's never been true for my whole existence. And so certainly the Christian perspective sees that suffering is part of the human condition, and it's a normal part of the human condition. Do we like it? No. Should we avoid avoidable suffering? Absolutely. But is suffering avoidable? No, it is not. From the Christian perspective, we worship a God who was crucified, who became man, and in his becoming man became subject to suffering and death, even death on a cross. And so what the medical community tends to miss, I think, sometimes is that if we cut ourselves off, if the definition of health is the absence of suffering or just like the ability to function, then we're also cutting ourselves off from hope, from joy, from purpose, and from the deepest meaning that life has to offer us, which normally, at least in my life, has come about in periods of great trial and suffering. And so there's a danger in pathologizing moral injury, really any disorder, as if it were simply a disease which needs to be eliminated. That's really a key distinction. Now, what does that mean for this conversation? So, since moral injury has been described, it has been a subclinical issue. Moral injury, as of today, is not a diagnosis in the DSM. I propose to you will be soon, and that'll be good and bad, and that's why I'm having this conversation. But we see chaplains, certainly, military chaplains, that moral injury is, unlike PTSD, is primarily a spiritual crisis of meaning. There is a big difference between cognitive functioning, as if, the machine of your mind or your brain is working. You just need to change the spark plug, and meaning and purpose and values. Our goal as chaplains is to understand. I believe in integration with mental health, to understand all those aspects of cognitive functioning that are important. But we're always about trying to get to the story. Tell me the story underneath this suffering. Tell me the story underneath these symptoms. Tell me the story underneath this presentation. Because that's really where the symptoms emerge from the person and the story. And there's a danger of losing the person and the story in the midst of trying just to treat the symptoms. So a couple years ago, I attend conferences online and in person. I attended an online conference, and it was the Harvard Human Flourishing Program's sort of annual update, and it was a global summit on moral injury. Now, there was all kinds of amazing things presented at this conference, but one of the things presented was sort of a report by the Human Flourishing Program. Now, I want to say up front that everyone I'm going to mention, I think, is a friend. A friend not only to the research community, but a friend to the chaplain community as well, and would see themselves as that, not as adversarial or anything like that. Um, and this team, the Human Flourishing Program, to my understanding, is maybe the largest research study ever conducted by the Baylor Institute of Religion, ISR, by Harvard. I mean, there is massive amounts of interest and money, and there's all kinds of aspects to the Human Flourishing Program that they're doing research around the world. And they talk openly about faith and about religious practice and its impact on human flourishing and human happiness, which is the right, I would say, the right framework for understanding how the mental health community can better align itself. Well, part of this presentation was an update on moral injury, and Tyler Vanderweel, who is the head of this project, presented essentially what was a future proposition for a moral injury disorder in some future revision of the DSM. So this was a huge shock to me. I don't know if it was to others, but the way that I read this lecture was basically, hey, guess what? We've already done all the work. Here's what our proposed criteria, diagnosis criteria, and exclusion criteria could be. And by the way, we're submitting this to the APA with the desire of having, an end state of a moral injury disorder diagnosis. So thus far, moral injury has been a spectrum, but there has not been a definitive diagnosis. Some people have suggested things like post-traumatic stress disorder with moral injury features. Like there's so many ways to make the sausage with diagnosis and those kinds of things. I want to say too that um, diagnoses have changed. Like if you look at the DSM-4 to the DSM-5 or the 3 to the 4, they do change. And in a sense, I don't mean this in a derogatory way. All of these ideas are made up. I don't mean to say that they're not real, but the diagnoses and the description, the criteria have changed. There's a real pathology that is observable and repeatable, but the way we talk about it sort of defines what the problem is and then how providers should go about treating it. You hear that language of treatment again, right? Which sees it as a disease. Um, so in the past, we've talked about there being potentially morally injurious events. So that's the time where something happened and that thing that happened could be moral injury or it could not be. We've talked about moral distress as part of the spectrum. I mean, any of us that are adults living in the world experience moral distress. I mean, you can be a lawyer, you can work in the medicine, you can work in the military. I mean, just living life creates moral distress. But then there comes a point in the spectrum model where we can say this is properly moral injury, where someone's core moral beliefs about right and wrong have been harmed. And moral injury is more than just ethical lapse. I contributed a good deal to the moral injury playbook that the Air Force uses. And we see moral injury as sort of a shattering of the belief of moral law, of real morality, as C.S. Lewis would call it. So it's more than just ethical lapse. It's sort of a shattering of the belief that morality is real and operative in the lives of people. Um, so that's the historical model of the spectrum. And in that model, chaplains have been able to enter in because really what people are looking for who are struggling with moral injury, I would argue, is forgiveness. In fact, I would argue that all of the modalities which have been developed, like cognitive processing therapy and others, are basically religious understandings that have been understood for centuries reskinned. I mean, if you look at the Roman Catholic rite of confession, for example, what does the penitent person do? They have a besetting sin. There's something weighing heavy on their heart that they did or failed to do or witness, let's say. They go to the priest and they say, Father, forgive me, I've sinned. So they own what happened. They don't invalidate it. They don't avoid it. They say, no, I messed up. Okay. And then, the priest gives his response and then you're like, here's what I did. And they name it. I failed to do this. I was unkind to my wife. I was whatever. And if you've talked to Catholic priests, I mean, they hear all kinds of profound things that people have done. So the sin is named, the besetting sin is named, and then the priest offers not only a reminder in the Catholic understanding of God's forgiveness, but an assurance of God's forgiveness. And he acts in the person of Christ in persona Christi, and in his name says, in the historic model, that te absolvo, which is like, I forgive you. You're forgiven. And a priest in that moment is not just speaking as Father Bob or whatever. The priest in that moment is speaking the words of God to this person who is grieving and who is needing to be uh, unchained from all that they are experiencing. Um, I still think that's sort of the standard approach for chaplains, for people who are dealing with moral injury. Now, this new team, the Human Flourishing Program, if you see the photo I have in the attachments of my LinkedIn profile, they're suggesting, yeah, there's still a spectrum, but there's actually this quadrant up here. Could it be that people who have a high persistence, high acuity moral injury, could it be that they have what we would call a moral injury disorder? And from my understanding, really the only criteria is persistence and acuity. So I think we would all agree that if, and this is, I've seen this in my own ministry, that if somebody is struggling with moral injury so profoundly that they don't sleep, they can't get to work, it's destroying their marriage. They're drinking, themselves silly. Like there's all kinds of functioning questions that are properly a part of, the mental health system and their concerns. We would all agree that such a person should get help, right? Um, the question is, should those things alone create a diagnosis? So that's really where I think we're heading. In my opinion, this team is the most influential research team in the world. Um, and I also think, and this is an important part of this, is that most chaplains don't understand how the mental health system and the medical system actually operates. So if you work in the VA and you chart for patients, maybe you understand this more, but certainly military chaplains do not understand. So in order for, if you say you have a mental health condition, you go to a provider and they do 1 hour of cognitive behavioral therapy. Well, they don't just take notes. Like they have to go into a system like Epic or MHS Genesis or some other system and say, for the bean counters now, I did 1 hour of cognitive behavioral therapy for this patient. Okay. Well, then the systems, the medical system, certainly the insurance companies are asking, well, why'd you do that? Well, in order to answer that question, what does the provider have to do? Well, more often than not, they have to diagnose. So you can't just say, well, I did 1 hour of cognitive behavioral therapy and I'm charging them X amount of dollars for said therapy, and I'm charging you, insurance company, X amount of dollars for said therapy just because life is hard and the human condition, is one of suffering. No, no. Providers have to label it, and that labels a diagnosis, and that diagnosis requires what's called an ICD code. So, uh, there's a lot of sort of low level diagnoses. Like when I was in the clinic, adjustment disorder. People everywhere were getting diagnosed with adjustment disorder. And I'm not trying to invalidate that diagnosis, but I would also say adjustment disorder is part of joining the military when you're 17. This is it a pathology? Or is it just normal? Is it to be expected when a young person is making this radical life transition into military life? Other common diagnoses: generalized anxiety disorder, major depressive disorder, like these have exploded since 2008 in particular, because I would argue because of social media. Arthur Brooks would say that as well, but that's for a different day. But the end result is that, in my opinion, and the opinion of many people, both providers, chaplains, medical doctors, there is a tendency to over-diagnose, to overcode, and to over prescribe, right? So, you come in, you quickly get a diagnosis. Standard of care is like an SSRI or an SNRI. Person goes on that prescription, ICD codes attached to their record. they're diagnosed with, and then they begin to identify with that diagnosis, which is oftentimes counterproductive to what the provider is looking to do. Um, so imagine a system like this that has its own interests, the insurance company looking to decide how to pay for things, the research community who are wanting more funds to do research, our own, this is on LinkedIn, like our own career desires to be a part of research, to be a part of an emerging field, all that. Those are all interests. People who write studies are human beings. And human beings, just like me, are subject to the conditions of sin and self-interest, right? Um, Now, I don't think that's the case. And I think that's really what I want to get to, the rest of the time here is that I think everyone who's involved in this conversation have the absolute pure intentions. But those intentions may manifest and present, and there may be second and third order effects, especially in military chaplaincy, that were not expected or that were not anticipated. So, like I believe absolutely that if there's a moral injury disorder in the next DSM revision, which of course is not up to me or any of us, that it will help increase access to funding. It will help uh, with shared language, which is such an important part of diagnosis. It will help with more research. It will help with access to care. It will help with maybe even access to chaplains. And so this is what people see in the windshield who are arguing for the advancement of moral injury as a definitive diagnosis. They're like, this is great. There's nothing but good things that are going to happen because, and they're right. I mean, there's a lot of truth in what they're saying because, they would say things like moral injury is not just a military problem. There are people all over the civilian sector who experience moral injury. There are firefighters, there are first responders, there are police officers, there are lawyers. I mean, if you've worked in the legal system, you're probably morally injured because you've done things, you've seen things done, you've witnessed things that violate your core beliefs about right and wrong. Is there like a job on the earth where moral injury is not operative? Probably not, because we would say moral injury is basically the fall and the human condition and the results of sin. I mean, Lord knows if you're a pastor, if you've been a pastor, you've been morally injured. I mean, a lot of people say if you're a minister who gets paid for their faith, at the end, you'll have one or the other. You'll have your paycheck or you'll have your faith, because inevitably, working in a nonprofit or a church environment will challenge whether you keep your job or whether you keep your faith and your belief in God and or the church or the religious community or what have you, right? So there's nothing but good intentions behind this desire to make moral injury a full diagnosis and disorder. Here are some thoughts I have, though. Um, so I think if you're a VA chaplain or if you're working in the medical system for like a private hospital, it's probably mostly good. One of the things that's already happened is the advancement of moral injury or moral distress or concerns as a Z code. Now, this is a profound step. It's hard to overstate how dramatic this change is. I've been trying to tell chaplains, especially in the military, for years that this is coming. And I have been ignored by many of them. Senior chaplains have said, this is never going to happen. It's not relevant to the work we're doing. If it does happen, it'll happen 10 years from now. And, I want us to align our ministry towards reality, what's actually going on in the research community and the probable direction of teams like the Human Flourishing Program. Um, well, now, this whole category of moral distress is a Z code. So if you're a chaplain in a medical environment, if you chart or if that's part of your practice of ministry, then you can reference that Z code as part of your practice. So I think part of the intent is like, this is going to help chaplains because now they can code like providers code, and then that'll help justify their work. It'll help justify manning. It'll help them get paid, right? I question if is that the right framework, for an ordained person in ministry. but I see the merits of the argument as well. So it could be a great thing. Like if you're in the VA, that look at the number of moral injury patients we have been helping over the last 6 months. We need another 2 chaplains on staff because of the utilization that we are seeing in our chaplain program. So that could be just like a solid win, right? But so often the things that work in the civilian sector are counterproductive in the military system. So one question I've had is, okay, so the next step is probably to create an ICD code for moral injury. And currently, in parts of the military, the chaplain corps is the one taking the lead on moral injury because it's understood to be unlike a purely like physiological condition or like other mental health conditions. Like people recognize the spiritual aspects of meaning making in the moral injury conversation, and especially guilt and shame, which are often beyond the practice of a provider. I mean, you're not going to go sit down with your mental health provider probably and say like, "Where's God in all of this? I need you to be my priest." Like, what are they going to? Or I need you to be my pastor. Or, I need you to offer me transcendent forgiveness from the universe, like whatever, however you describe that, that's probably not going to be something your mental health provider A wants to do or two even has time for. I mean, if you understand how often they have, how much time they have for patient interactions, on a in a clinic environment, right? Um, so if there's an ICD code, it could be that like the mental health community sort of emerges as the primary care provider for moral injury in a military context. It could be if there's like let's imagine that 3 or 4 or 5 years from now, there is a full blown moral injury disorder in a DSM-6 or a future revision. Are we going to have military members who for 20 years now want to be diagnosed with moral injury disorder because of what happened? Um, and then will that diagnosis be considered as part of a disability rating? I don't know. Like, good questions. I mean, if we say this is a distinct diagnosis and condition, and not just a part of living in the world that needs to be understood. It needs to be approached from an integrative perspective. But it's a no kidding a true diagnosis. Then will that have a determinate effect on disability VA claims? Like who knows, right? Um, I think more in the short term though. Uh, what does that leave for the role of chaplains? Right. So if this is primarily a mental health condition properly understood, chaplains in the military do not chart. We do not, except in a very few cases, do not have access to MHS Genesis, which is our charting system. But even more importantly, military chaplains have privileged communication, or which is more profound than most people understand. Under the military rules of evidence, a chaplain cannot share what was said to them in confidence as an act of faith or as a matter of conscience in counseling. So we are, in essence, mandatory non reporters. So without the express written permission of the care recipient or the patient or whoever, we cannot share what is said with us. And that's part of our sacred trust as chaplains. And it comes from the First Amendment and the Constitution. And it comes in part from the Catholic tradition of confession and the guarantee of that privileged uh, clerical status for all members of the military, so that their First Amendment rights to free exercise are not limited by military service. So a chaplain, couldn't tell somebody or a provider, if you will, about an airman or a soldier who is struggling with moral injury. So how does that, if we had small groups, let's say, or like there's a tool called Understanding Moral Injury that I'm really interested in. How do we care for people as pastoral ministers, recognizing that there is a central spiritual crisis of meaning and a need for forgiveness, uh, with people who are experiencing moral injury, while also needing to protect our privileged communication, our, the desires of the care recipient and what have you. So I think there's a lot of opportunity in the future for where moral injury goes. I think that I think it's inevitable that it's going to be further medicalized and pathologized. I think it's inevitable that there will be an ICD code, and the people who are doing this are many of them are I would call friends, um, and I think that we have to start thinking about what does that mean for us as chaplains and especially as military chaplains. How can we have relationships with the mental health care team? How can we have memorandums of understanding? Does a chaplain understand where his or her abilities end and where referral needs to happen, especially for like adjacent issues of substance use disorder or PTSD or any of these other things that could be co-occurring? And maybe as importantly, maybe more importantly, is like, does the mental health community, do they know what moral injury is? And do they know where the line is to refer to chaplains for the specific care and pastoral care that we provide, especially when someone has a loss of faith, which is common, a loss of religious identity, questions about God, questions about forgiveness. Um, I I know a lot of people in the military who want us to get there, but I don't know a lot of people who are currently getting us there, right? So that's a big question I have as a military chaplain. Um, if this is the future that's coming, how can we best situate our ministries to provide the best possible care in this emerging consensus view? Um, I don't know. Lots of good questions. I think if you're interested, the moral injury playbook is probably a good place to start. We recommend tools like the moral injury symptom scale, the military version short form, which is a scale developed by Dr. Harold Koenig, who's I was just with yesterday, and who is a great supporter of chaplains and structured pastoral approaches and all of that. And this is a formal moral injury assessment that is currently being used in the Department of the Air Force. And the goal is not to co opt all this other stuff, not to co opt the medical system. The goal for us in the adoption of uh, pastoral assessments, spiritual assessments, which have been around, many of them for decades, is always to occasion pastoral conversations. If you hear nothing else, hear that. The goal is to occasion pastoral conversations. The goal is not to become a clinician. The goal is not to become a counselor. The goal is not to become a provider. The goal is to help other people discover your role as a pastor, as an imam, as a priest, as a rabbi, and to offer what you already have to offer, right? One of the things that's said in the playbook is that the majority of things that a chaplain needs to know, he or she has already learned in seminary. Your tradition already has something to say about moral injury and something to offer, whether that be confession, whether that be another kind of ritual, whether that be mindfulness, based meditation or mindfulness based stress reduction. Like I am absolutely confident that your theological formation is ready and willing to say something about this question of moral injury. So that's kind of, I guess, concludes the conversation for today. Um, I think this is coming. I think there's a medicalization is the route where we're ultimately going to end up. Some people disagree. Some people say, even a few mental health providers I know think that there are other ways that this could work out. I think more than likely moral injury disorder will be a future diagnosis in the DSM. I think there'll be a lot of good that comes out of that. I think it will increase access to research. It'll increase shared understanding. And I'm part of, communities that are looking to do research like that, like prevalent studies, which have not been done at scale. But I think there's also going to be a lot of second and third order effects, and that we need to anticipate those things and then figure out how to best situate ourselves to do wonderful ministry in an age of moral injury, in an age of potential conflict in the future and conflict in the present moment. So appreciate your time. If there's other topics like this that you want me to discuss, or if there's something I've said today that sort of pricked your imagination and you wanted to know more, let me know in comments. Let me know on LinkedIn. And if there's enough interest, I could record a video like this, once or twice a month. I think other topics could be like post-traumatic stress disorder. We could talk about moral injury in a particular community, like the ISR community. We could talk about integration of mental health and chaplaincy. We could talk about religion and like acceptance and commitment therapy. We could talk about mindfulness-based stress reduction from a chaplain's perspective. Yeah, there's a lot to explore. But I hope this has been helpful. I hope it answers some of the questions that so many have been asking. And yeah, let me know. Thanks.